Good evening, Ranjit sir. Sir, you are mute, sir.
Okay.
Yes, sir.
Is that okay?
Yes, sir. Krishna Kumar sir is already here, and
Yeah.
Dr. Meghna, she's also here.
Okay.
Good
This is
evening,
my
sir.
first. This is my first time, not the student's first time. First time. Yeah. Okay. Dr. Krishna Kumar is from SUIT, no?
Krishna Kumar sir is from Shri Chitra, sir.
Yeah, Sri Chitra. Yeah. Yeah. Amit Thakur there spoke. Yeah. Good evening, sir.
Good evening.
Good evening. How are you, sir?
Yeah, good evening. Fine.
Nice to
Sir.
see you, sir.
Same here.
Dr. Amit Thakur, you studied with you. He is in Pune now. So we are co-workers in Manipal now.
Yes, yes.
Sir, can we start, sir?
Yeah,
Please.
sure.
Dr. Meghna, are you ready?
Yes, sir.
You can share your screen. Yes. You can
Yes.
start. So, sir, the rules are same. For Dr. Meghna, we'll ask the questions to the other candidate, Dr. Chaitanya Raj. Dr. Chaitanya, are you here?
Sir, is my screen visible?
Yeah, your screen is visible. Dr. Chaitanya, is he here? I think he's yet to join.
I don't see him here, sir.
Yeah, it's yet
It's
to
from
join.
MS.
So for Meghna's presentation, you'll ask questions to Dr. Chaitanya and vice versa, sir.
Yep.
And if Dr. Chaitanya is not able to answer, then the question goes back to Dr. Meghna. We have long case. For long case, we have 60 minutes, sir.
Okay.
30 minutes for each. Chaitanya is here, so we can start.
Sir, is my screen visible?
Yes, Dr. Meghna.
Yeah, yeah.
You can start.
Okay. Good evening, sir. My patient's name is Mr. Dilbag, 42-year male, hailing from Haryana, studied till 7th standard, farmer by occupation. He is a right-handed person, informant to self and nephew, and reliable. Presented with chief complaints of restricted neck movements since 5 years of age, stiffness in all four limbs since 2 years, difficulty in walking since 1 year, and suboccipital headache since 6 months. The patient was apparently well until the age of 5 years when he sustained a trauma to the neck following a fall from bullock cart. There was no history of loss of consciousness, seizures, or immediate neurological deficit at that time. Since the injury, he developed persistent restriction of neck movements involving all directions, more marked in rotation, and side to side movements. The restriction has remained static over the years. There's no history of neck pain, shock like sensations, or any history of spine deformity. About 2 years ago, he developed gradual onset stiffness involving all four limbs, insidious in onset, slowly progressive, more prominent after rest, and partially relieved with movement. Initially in the lower limbs, asymmetric, involving the right leg, followed by left leg, followed by upper limbs. He initially noticed that he was unable to lift his right leg to sit on his bicycle as he felt that his leg was heavy as a log and did not bend freely while pedaling. Slowly, he started to notice that he was finding difficulty in initiating walking as his legs felt heavy to lift, and over the course of illness, he noticed that he was unable to walk at previous pace as he felt his legs were crossing and dragging. He found walking in the fields, or that is on an uneven surface, difficult. He also noticed that previously he was able to milk the buffalo in squatting position and get up on his own, but now he needs someone to lift him up as he feels he's stuck in that position. He is unable to negotiate his legs into the pant while standing. He has also noticed that stiffness has increased over the past 2 months during winter to involve the upper limbs. At present, he needs help of one person for ambulation. There's no history of difficulty in wearing slippers. There's no history of difficulty in getting up from bed or turning on the bed. There's no history of thinning of limbs. There's no history of difficulty in buttoning or unbuttoning the shirt or difficulty in eating. There's no history of difficulty in raising arm above his head. There's no history of difficulty in gripping objects. There's no history of muscle pain, flexor spasm, fasciculations, no fluctuation of stiffness, no episodic worsening or remissions, no history of reduced sensations over the limbs. About 1 year ago, the patient noticed difficulty in walking in the form of imbalance while walking. He describes a feeling of unsteadiness while walking, especially on uneven surfaces. Previously, he used to work in the field till dusk, but then he started to notice that his imbalance worsens in the dark and has a fear of fall. He also noticed that while washing his face, he feels unsteadiness and holds a sink basin while washing his face. He has also noticed that his slippers slip off from his feet without knowledge and only becomes aware when his caretakers tell him. However, there's no difficulty in gripping the slippers. No history of tremors, smearing of food, or slurring of speech. Over the past 6 months, he has also been experiencing suboccipital headache, which is insidious in onset, dull aching, non-radiating, aggravated on coughing, and partially relieved by rest and analgesics. There is history of change in voice observed by attenders in the form of nasal intonation. However, there is no history of nasal regurgitation. There is history of cough while eating. No history of recurrent LRTI. No history of diplopia, blurring of vision. No history of deviation of eyeballs. No history of facial deviation, decreased hearing or tinnitus. No history of dysphagia. No history of tongue deviation. No history of bowel or bladder involvement. No history of joint pains or stiffness. No history of evening rise of temperature, night sweats, weight loss. No history of respiratory distress. And no history of recent trauma. The past history is non-contributory. Family history, there is no history of similar complaints in the other family members. No history of active communicable diseases in other family members. Personal history, he takes a mixed diet. Bowel and bladder habits are regular. Sleep and appetite is normal. And there is no habituation. My summary is a 42-year male with past history of trivial trauma, followed by restricted neck mobility and gradually progressive stiffness involving all four limbs, along with imbalance while walking, worsening in dark, with post-tussive suboccipital headache, with recent onset nasal intonation of voice and coughing while eating, without any sensory, bowel, or bladder disturbances. Should I continue, sir?
So you can ask questions.
So was it only restricted neck mobility, or he had torticollis since that era?
Based historically, he was saying he was unable to move his neck, sir. So he was saying of restricted neck mobility itself. He did not say that his neck was turned to one side or
There was
anything.
no tilt, no fixed tilt.
Hello.
There was no fixed tilt as such.
No, sir. There's no history of neck tilt. No, sir.
So according to the history,
Yes, sir.
what are the anatomical substrates you feel are involved in this patient?
Sir, based on the history, first complaint was restricted neck movements, which I would localize it to musculoskeletal. It could be secondary to trauma or it could be congenital also. Congenital cannot be ruled out. And coming to stiffness of all four limbs, it is localized to bilateral corticospinal tract above C5 and below cervicomedullary junction. Imbalance while walking, which is accentuated in the dark, I am localizing it to the dorsal column, sir, in the upper cervical region. And post-tussive suboccipital headache, it could be because of the C2 nerve root. And nasal intonation, which he told, recent onset nasal intonation, it could be involvement of 9th or 10th cranial nerve. Could be nuclear or infranuclear. Hello.
And considering the order of progression with which
Yes.
these symptoms evolve,
Yes, sir.
in the horizontal localization, horizontal level,
Yes, sir.
where would be the lesion persisting in this patient?
Sir, more likely It could be an I was considering an extradural lesion in this case, sir.
Okay. What are the two major points which support extradural localization?
One is um, the pain that he says, and the other thing is the stiffness, sir.
Is the pain fitting into any of the known pain syndromes?
Sorry, sir.
Is the pain fitting into any of the known pain syndromes that we know of? In other words, is there any radicular component to the pain? Is there any radiculopathy for this patient to begin with? Or this is clinically, this is a pure myelopathy, devoid of any radical.
It could involve the C2 nerve root, sir. I had kept a possibility of C2 nerve root in this case, considering the suboccipital headache that he was complaining of.
Okay, that could be dural stretch pain also.
Yes.
It may not be a radicular, but if C2 root is definitely involved, the patient, a leading question can be asked to the patient whether you want to know conclusively whether the C2 root is involved. What is that pertinent question that we should ask?
Sir, we can ask Dr. Chaitanya also. He should be involved to the other candidates.
Yeah, other candidate.
Dr. Chaitanya, are you there?
Let him analyze this and ask questions.
Yes.
Chaitanya, you are not visible. Hello, Dr. Chaitanya, you there?
Yes, sir.
Yeah, so sir has asked you about the extradural pain, whether it is C2 neuralgia or it is dural stretch. How would you analyze that? So she has noted it as a suboccipital post-tussive headache. Post-tussive headache is commoner in what?
This is more in Chiari, the tonsillar herniation. And we can ask for analgesia of the occipital dermatomes.
So what is the pertinent question that you ask to confirm whether it is C2 or it is impaction syndrome?
Any analgesia over the neck or the occipital region?
Yeah, that is one question we should be asking. Yes.
Paresthesia along the
C2 hypoesthesia. C2 hypoesthesia is the commonest symptom they tell if C2 root dysfunction occurs, which is not at all connected with the dural stretch pain as described in Chiari.
So they would say numbness, and they would show a particularly hand distribution. When you put your hand behind your ear vertically, so that would be distribution where they would say pain, paresthesia, or numbness.
Okay, sir.
And Dr. Prashant, can the candidate ask more questions to Dr. Meghna, and then we should proceed? What is the format?
Sir, the format is as per you wish. If you think he should be asking her questions for more details, he can.
Dr. Chaitanya, can you ask more questions, analyze the historical part, and then we can proceed to physical exam.
I think we can proceed to examination.
Now, any more aspects in history which the candidate who presented has not given stress, do you feel, Dr. Chaitanya?
So far, I have no doubts, sir.
Okay. So, is it a progressive disease in a particular fashion, progressing in a particular fashion?
I guess, sir, it is gradually progressing, involving.
So does it give a clue regarding your horizontal localization, the progression?
She has said.
So in what way does progression help you in horizontal localization? Vertical localization is almost we have reached, but what about the horizontal localization? Whether it is pure extradural, intradural, extramedullary, or intramedullary, will the progression pattern help?
In this case, pattern of limb involvement can also help us localize it vertically.
Would you like to ask more leading questions to Dr. Meghna?
She has already talked about the limb involvement, sir.
Yeah.
And the other is whether it is extradural or intradural. From here, pain and pain as cardinal symptom, and if in particular any radiculopathy is present.
Okay.
Versus
So
any
if it is
genicular pain.
if it is a significant extradural compressive pathology, what will be the pattern of evolution of symptoms pertaining to the limbs?
At the level of foramen magnum, sir.
No, my question is, there is an evolution of symptoms. It
Yes.
didn't begin all of a sudden.
Yes.
There is a particular pattern which is followed. Which limb got involved first, then it progressed to which area. So if the progression is noted in a particular fashion, will it help you in horizontal localization?
Yes, sir.
Yeah. Can you explain?
Because there is a differential decussation of the tracts from the lower limbs and the upper limbs, and the upper limb fibers decussate at a more cranial level, at the level of foramen magnum, as compared to the lower limb fibers, so which will decussate at around C1 level.
No, that is the concept of cruciate hemiparesis. We are not asking about cruciate hemiparesis.
So using this, if there is any extradural compression, I can differentiate a vertical extent based on the pattern of limb involvement.
Yeah, in what way?
If it is at or below the level of C1.
No, in other words,
Ascending pattern of weakness.
yeah, exactly.
To differentiate between extramedullary and intramedullary, ascending versus descending pattern of weakness.
So in this patient, is it ascending pattern or descending?
Sir, in this patient, according to history, it was descending pattern of weakness. Sorry.
Okay. So that could be due to some other reason. We have to analyze the history again and come to know about it. So there are some patterns which are shown by this patient. And one more thing regarding the autonomic disturbances which the patient has. In the history, it was presented that there is no bowel or bladder disturbance. Is that enough or more points?
Whether there was any postural hypotension for that, or if the patient has
the history, what are the symptoms of dysautonomia in such patients of this localization? Above C5, mostly at the region of the craniovertebral junction, what are the dysautonomic symptoms the patient will have? Symptoms of dysautonomia or autonomic dysregulation.
postural hypotension, Horner's features of Horner's syndrome.
Exactly. One is Horner's, yes. So we can split it into parasympathetic and sympathetic. So sympathetic, one is Horner's. Any other feature they will show? Can they have limb gigantism, upper limb gigantism? It's called sympathetic hand. Pictures are there in most of the older textbooks called sympathetic hand. Have you heard, both of you heard of sympathetic hand? So sympathetics, they maintain the vasomotor tone of the blood vessels. So if sympathetic tone is lost, then there is extravasation of fluid. So there will be skin changes. There will be limb edema causing gigantism. So that is in a patient with at least 5 to 6 years of history, we should be asking history regarding that also. Is one hand feeling, the dress is feeling tight? Is he having loss of sweating of that involved area? Okay. Easy bruising, shiny skin on exam. That's all an examination. But dysautonomia should not be ignored at all. Bowel and bladder symptoms may appear little late, but symptoms of sympathetic dysregulation may appear early because of this particular localization.
Okay.
And what about considering that he is a laborer? Is he able to execute fine actions with his hand like before?
Yes, sir.
So
Historically, yes, I had asked him
like
regarding the buttoning, unbuttoning of the shirt, breaking chapati. He is able to do fine motor activity in the bilateral upper limbs, and he does not have complaints in the upper limb as
considering a
well.
localization of veniovertebral junction, does it hand weakness or weakness of the intrinsic muscles of hand, can they occur, and why?
Yes, sir.
Historically,
There can be weakness of the intrinsic muscles of the hand in CBJ anomalies because of two reasons. One, because of the venous congestion that happens, and two, because there could be an underlying syrinx formation which can lead to
so considering the particular pattern of involvement of the limbs
yes, sir.
in your pathology, which may be localizable to this level, are you considering affection of the anterior horn cell level as well as syrinx formation also?
Sir, but he does not have
Chaitanya, would you,
any he does
Chaitanya
not
can
have
also.
any complaints in the upper limb as such, sir.
Okay.
And there's no motor historically there is no motor involvement of the upper limb. So, but there could be a syrinx formation.
Okay. So when somebody has a nasal twang of voice developing
Yes,
with
sir.
nasal regurgitation of fluids, regarding his respiration, what are the couple of questions you can ask in the history regarding his respiratory reserve?
Whether he is able to finish sentences, whether he is able to whether he is having recurrent LRTI and recurrent fever LRTI. And
One is due to micro aspirations, but
yes, sir.
respiratory reserve is counted in other ways in physical examination also. So if he is a religious person, we can ask for these chants which they do during religious purposes. Whether he is previously he used to a religious chant, several pages he could finish, but now he could not. So there are some ways in which, according adjusting to their profession. Otherwise, social events we can couple and get a rough assessment of the respiratory reserve from history itself. So I think the history was lacking a little bit of autonomic disturbances as well as respiratory reserve, which is very much paramount importance considering the surgical point of view also.
Okay, sir.
So, Ranjit sir, anything?
No, that's all. Yeah, apart from venous congestion, cruciate paresis or Ellsberg phenomenon that can cause directly symptoms in hand and small muscles also.
Okay, sir.
Can we proceed with the examination, sir?
Yeah, I think so.
Dr. Meghna, you can proceed.
Yes, sir. General physical examination. The patient is welcome, conscious, cooperative, well oriented to time, place, and person. There's no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema. Vitals pulse rate is 82 beats per minute. BP is 110/70. Respiratory rate is 18 cycles per minute. Height is 162 centimeters, weight is 70 kg, neck length is 10 centimeters, neck height ratio is 0.06. Patient has short neck, there's low posterior hairline till C7, there's no low set ears, no feature suggestive of Horner's syndrome, no neurocutaneous markers, there is kyphotic deformity, and the patient has bilateral pes plans. In systemic examination, the trachea is midline, chest circumference is 63 centimeters. On tidal percussion, there is expansion of two intercostal spaces. Single breath time is around, he's able to count till 1010, and breath holding time is 26 seconds. Chest expansion is 3 centimeters, and normal vesicular breath sounds are heard. Rest of the systemic examination is within the normal limits. In CNS examination, higher mental functions is normal. In cranial nerves, olfactory normal. In optic nerve, visual acuity is 6/6 bilateral eye. Fundus is normal. Pupillary reflexes, both direct and consensual, are normal in bilateral. 3, 4, 6 extraocular muscles are full and free. There is downbeat nystagmus in primary gaze. Gaze evoked nystagmus is present with high frequency and low amplitude type. Fifth nerve, seventh, and eighth all are normal, sir. In 9th and 10th, palatal arch is symmetrical, uvula is midline. In gag reflex, the sensation was impaired on the left side and gag reflex was also absent. 11th, trapezius power is normal. Sternocleidomastoid could not be tested, sir. 12th, hypoglossal nerve is also normal. Motor, tone, bilateral upper limb, there is MAS grade 1 spasticity, and in bilateral lower limb, it is MAS grade 2 spasticity. Bulk is normal in bilateral upper and lower limbs. Power, bilateral upper limb in all joints is 5/5, and in lower limb, bilateral hip flexion is 4+/5. However, rest of the joints it's 5/5. In reflexes, bilateral upper limb reflexes are 3+, and Hoffman is positive. Bilateral lower limb, in the left patellar and ankle, there is sustained clonus, and on the right side, the reflexes are 3+. Bilateral plantar is extensor. In sensory examination, touch, pain, and temperature is normal. Joint position sensation is impaired at the toe and ankle, but in upper limb it is not. Vibration, he was giving an unreliable response, sir. Romberg's test is positive. Gait is spastic ataxic gait, and there is no cerebellar signs present. Hello.
Yeah, we are here.
We can hear you, Dr. Meghna.
Dr. Chaitanya, can you analyze this history and, if necessary, ask more details?
Was there any mention of sensory?
Yes. In sensory examination, pain, touch, and temperature is within the normal limits. However, vibration, he was giving an unreliable response. Joint position sensation was impaired at the toe and ankle. In the upper limb, it was normal.
Since the history was favoring a localization of extradural lesion, the neurological examination is not complete without one more aspect. Can you elaborate on that? Doesn't stop with cerebellar signs. Something else need to be examined. If you see the headings under which we examine the central nervous system, we follow an order so that nothing is missed. But this is very pertinent if the lesion is localizable to the extradural region, not like an intramedullary with mechanical kind of pain.
Tenderness.
Skull and spine. Skull and spine is examined.
Yes, sir.
Very important. So what are the findings you can pick up in such patients? When you are
One, whether
examining
the patient
spines,
has any localized bony tenderness.
yes,
Two, if the patient has any kind of spinal deformity.
yeah,
Three,
Timbers.
yes, sir.
Already
And
you told about kyphotic,
yes, sir.
but in such patients you expect another deformity. What is it?
Um,
In a craniovertebral junction compression, they may develop serines. So what do they have?
Scoliosis.
Scoliosis. So some of these scoliotic children, when they go for scoliosis correction, the CV junction anomaly gets detected. And then extensive serines formation, the paraspinal muscles go weak. That produces segmental scoliosis.
okay, sir.
So that was something which, and if we go, do you think there is definite short neck for this patient, considering the neck height ratio? Does he have external markers of a CV junction anomaly? Dr. Chaitanya, are there any external markers of CV junction anomaly in this patient?
She mentioned one as a low posterior hairline, sir.
Okay.
So, what are the remaining stigmata of CV junction anomalies that she has not mentioned or not seen?
Facial dysmorphism, webbed neck, and
Then
any,
one more very common. Or two.
yes, sir.
High arch palate and Spengler deformity.
Okay, sir.
Also in the systemic examination, there was a mention which I didn't get clearly, that single breath count up to 1010. Can you explain what it is?
Sir, I had asked the patient to to take a deep breath and for how many like 1001, 1002, 1003, how many he is able to tell in that single breath. So he was able to tell till 1010.
So what is the inference that the examiner gets if he can count up to 1010?
The tidal volume of the patient can be, it is a gross estimate of the tidal volume of the patient as single
Yes.
breath.
Yes. So what about this patient? Is it impaired, normal? Do you have any standard for that? For example, if your patient was a mathematics teacher, that person will count very nicely up to maybe 1050 in one breath. No problem. Because they are teaching every day mathematics. But does that mean that the respiratory reserve is very strong and they will not have a stormy post-op course? They will not land up in tracheostomy? Never. So along with that single breath count, it is wiser to see your watch also and see how many seconds they take. And what
Sorry,
is
sir, I didn't get it, sir.
It is better to express it in seconds also.
Okay.
Let them count up to 50.
Okay.
Let them count up to 100. Let them say name of flowers. Let them say from January to December 3 times. Doesn't matter. But when they gasp for that breath, in a single breath, how much effort this is in a breath holding time, which is rarely done nowadays due to medical legal reasons also. Especially below 12 years, you are not supposed to do that, because to impress you, they may hold breath more than the desired time and they may go blue in front of you and collapse. So breath holding time, it's better only in a very cautious situation, but single breath count will give a very good impression. Without using a spirometer, you can know what is the respiratory reserve of the patient. So usually one person will have to take an extra breath to complete whatever effort he is taking to complete a series of sentences or words by around 15 seconds. Am I correct?
Yes.
Beyond 15 to 20 seconds, a normal person will find it very difficult. So in your patient, if you are looking at your watch while he is doing so, let him tell whatever, but it is put to stress. What is his respiratory reserve? His respiratory reserve is barely 9 seconds. They may count up to 1050, but it is your watch is showing 9 seconds. That means that his respiratory reserve is significantly affected, which supports your diagnosis.
Okay, sir.
Supports your diagnosis. Okay.
Okay, sir.
Right. And you said about wasting. So in this occasion, where you are suspecting affection of C2 root also, what is the wasting that you look for? The sensory part we told during history, that is C2 hypoesthesia from vertex till hairline posteriorly. Ranjit sir was telling, they will correctly tell. They cannot even feel the comb passing through their hair. But wasting wise, where will you examine for wasting? In a high cervical compressive myopathy like this. Chaitanya, can you answer?
So in high cervical cases, there may be false localizing.
No. Where will you look for wasting? Because your motor examination starts with bulk, then only tone, power, and reflexes. So in this situation, bulk should be assessed of which group of muscles?
Bulk here we look in the
C2.
For C2.
To look for C2 affection.
I'm not sure.
C2. LM and C2.
The neck muscles and sternocleidomastoid.
They are all supplied by some. It's a very common muscle. When you operate on prone position, you use your cautery to separate. What are these muscles?
Right.
The term is called suboccipital wasting. Have you heard of suboccipital wasting? So if there is suboccipital wasting, it supports your diagnosis of an LMN lesion at C2, suboccipital wasting.
Okay.
It will be very obvious. The back side of the neck up to inion, if you examine, if there is gross wasting, that supports your diagnosis. Most of these patients will have C2 hypoesthesia also. In the early stages of the history, they will have C2 root irritation, C2 neuralgia. It progresses to C2 hypoesthesia and suboccipital wasting.
Okay, sir.
What is your highest motor level after physical examination? What is the highest motor level after physical examination? Have you put analysis as another slide? Or you can tell what is your highest motor level. There are several levels which help you to localize. One is highest motor level, highest sensory level, highest reflex level, and highest autonomic. So what is the highest motor level for this patient? Dr. Chaitanya, what appears to you for the highest motor level for this patient?
So in this, the power on upper limbs is noted as 5 by 5 and lower limbs at hip flexion 4 plus by 5. So I will take it as L1, L2 at that level. But from motor examination.
Now you have an extensor plantar and upper limb reflexes, including biceps jerk, is exaggerated.
Yes, the reflex level is higher.
Yeah,
because Hoffman is positive above C8.
Hoffman is positive.
And upper limb reflexes, which is not mentioned, pectoralis or scapulohumeral. Yes.
Exactly. So one is Neck
Pectoralis is
muscles,
also exaggerated, sir, and also
that is
scapula.
all reflex level, but motor level, if we find that bilateral upper limbs up to deltoid are normal, even though there is hypertonia, you are getting a normal power for biceps, you look for muscle power above C5. So what are the muscles you can test above C5? How do you test anterior neck muscles? Is there a method to test these strap muscles of the neck, anterior neck muscles? You mentioned about diaphragmatic movement. Will that help? During tidal percussion, there was definite shifting of divergence. Does that add to your level?
Increased diaphragmatic expression will localize it to C3, C4.
Yeah, C3, C4, phrenic nerve. So if there is impairment at that level, that is your pathological level. Muscular muscular movement. Okay. Reflex level, yes, Hoffman is positive. And any strict sensory level for the patient?
Sensory was a little dicey, sir. Touch pain and temperature was normal, however, and vibration in JPS.
Autonomic level? Autonomic system is not in. So there is no strict autonomic level for this patient?
No, sir.
Okay. So given a situation you are getting, in many patients, we will get a strict motor level. There will be LMN at that level and UMN below.
Yes, sir.
Then there will be sensory level below which every sensations are impaired. You get a reflex level like we are getting in this patient.
Yes, sir.
Followed by an autonomic level. It could be upper limb, trunk, or lower limb dysautonomia. Yeah. Which among these four, which is the most important, which will help you to localize?
The LMN and sensory level.
No. Is motor level most important, sensory most important, reflex level most important, or autonomic most important to help you to localize? In a patient where all these four levels are available after a detailed examination.
LMN and where we find an LMN sign is that is the area of pathology.
Okay, I'll modify my question. Your motor level you got as C5. Sensory level, there's a strict C6 sensory level. Reflex level is like this patient, Hoffman also positive, pectoralis jerk positive. And there are mild signs of dysautonomia of the upper limb. So which level will you consider as the most important?
So most cranial level.
Yeah, that is the answer. Whichever is the highest level you get. In some cases, it may be sensory. In some cases, it may be motor. Some cases, it may be reflex level. But whichever cranially the highest level you are getting, that is the most important. That is your localization. So considering this localization, would you still would like to go for an extradural pathology or any modifications?
So sorry to interrupt. Last 5 minutes, sir. Then we'll shift to the other case.
Yeah. We are pathological localization. Dr. Meghna, pathological localization.
Pathological localization.
Pathological possibilities. The substrates involved you are told, but what are the pathological possibilities in this general? You can tell 3 differential diagnoses. He has pain.
Yes, sir.
Yeah. Pain could be due to one main pathology. What is that? Instability. Pain is equal to instability in neurological science, in spine.
Yes.
So what instability could have caused this? What fits him?
Atlantoaxial
subluxation with C2 rotary subluxation.
Yes.
Any other pure myelopathic syndromes you know of without producing radiculopathy? it must be there coexisting in him, but now because of the fall, it got worse. What is that? Pure myelopathy without radiculations.
B.
Chaitanya, any clues?
Syrinx, he might.
OPLL. A long segment OPLL will produce a pure myelopathy without radiculations. Third is India is a land of which disease?
TB.
So he could be having a CV junction.
TB.
Yeah, some inflammatory infective pathology going on.
Yes.
Could be rheumatic, sarcoid, TB, but India is a land of TB. Should always suspect that. Okay.
Yes.
So Prashant, you can guide us to next what we do. So you
Meghna, do you
arrived at a
have
provisional
the
diagnosis.
radiology?
Yes, sir. I have the radiology. Should I show the MRI first, sir?
Whatever
First show the
first is.
X-rays. In 1 minute, you describe the X-rays. That is what you miss, and examiner in final, they usually pull you to the X-rays.
Okay, sir. This is a neutral lateral flexion and extension X-ray of the patient showing hyperlordosis of the C-spine with C1 could not be made out in this, sir. And
So posterior arch of C1 is very well visible. So do you think it is occipitalized C1 or C1 is separate?
it could
Chaitanya?
be.
So C1 seems separate here. So.
Yeah. Then what do you see below that? Anteriorly and posteriorly.
Posteriorly, fusion of the spinous process of C2, C3.
So we cannot easily comment on that. It may be because of obliquity the spinous process appears large. There is a 2 lamina sign below C1. Then anteriorly, what do you see? Especially in the last image of flexion, neck flexion. What do you see? Take your arrow a little above, little up, a little up. Or?
Increased
Yeah.
ADI.
Can you comment on that on X-ray?
Retroflexion of the dens.
So you don't see it well. Odontoid is not seen very well, but anteriorly there is a very sclerotic, thick bone, like a saucer.
Yes, sir.
Like a saucer just behind the mastoid.
Yes, sir.
Mastoid obscures all this view, but then you have to look from there, search the lower margin of C2, posterior margin of C2, and from there move anteriorly and see whether it is something different than mastoid. So there is a bone between mastoid and the C2 and dens, which is very sclerotic, saucer shaped.
Yes, sir.
Okay, you can move to next slide. Chaitanya, describe.
You're able to see a hyperlordotic C-spine with it's a retroflexed dense seen here, sir, with retroflex dense with basilar invagination.
Okay. Then
Os, could it be? I was not very sure, sir, but could this be os? I was wondering.
Usually you
so
don't see anything in that area other than the anterior arch of Atlas, which should
so
have.
you first try to identify tip of clivus, try to identify basion, try to identify whether the C1 arch at least laterally is fused with clivus. Then see if there is occipitocervical joint, OC1 joint. Then you come posteriorly, see the body of C2 go upwards and follow it to see what is happening with it. If you see a separate bone from C1 arch and body of C2 or odontoid, then you can call it os. Otherwise, it's not an os. So what you see here is a hypertrophic dystrophic C1 arch, which
Okay, sir.
has caved in the C2 body, odontoid and C2 body and everything, and it is impinged between the clivus tip and C2 body, and that is what is causing a sort of posterior inclination of C2.
Okay.
So these two views, are they flexion extension or continuation of the same
No, sir. This is the flexion image, and this is the extension image, sir.
extension image?
The flexion and extensions.
Okay.
More information you will get from axial also. Yeah.
This was an axial recon image that was done, sir. The C1 arch is seen, but
So is there any rotary component which has come in the axial? Each CT in each plane will give you idea about the instability occurring in that. You saw the sagittal where you saw the anteroposterior translation
yes, sir.
and impaction causing gross destruction or impingement of the odontoid. Then
Yes.
the axial scan, which will give you a fairly good idea regarding the rotary component which has occurred again, which is, and the coronal will give you an idea of the tilts as well as deficiencies in the facet joints as well as the occipit OC1 and C1C2 joints. What is the, we are seeing 9 plates. Can you quickly tell the inference from reviewing all these 9 plates?
The anterior and posterior arch of C1 are well made out, sir, and even the common rotatory.
So to comment on the rotary part, we need at least 1 or 2 contiguous levels of the subaxial spine, because we always tell it in relation to the subaxial spine, C3 onwards. So if we get to know that, then that will be easy. Second is, when the complete arch of atlas is seen in a axial cut, how much of the odontoid process or how much of the C2 should be visible normally, if provided there is no neck tilt. And in this patient, what are you observing?
Not sure about that, sir. How much part of the
So
dent should be visible?
can you analyze the central image, top line central image? Can you analyze it? What do you see in it? That is the true axial. So what do you see? See from anterior to posterior, from posterior to anterior. What is that?
This is the denser that.
Correct. Yeah. Then
This one,
so you start from anteriorly, it would be easier. Yeah, from there.
this
Or
is
do
the
you see that?
anterior arch of the C1.
How come it be anterior arch of C1 if
Oh,
it
sorry,
is
this is the
contiguous with
anterior.
the mastoid?
Yes, yes.
That bone is contiguous with mastoid, so it has to be clivus,
Clivus.
lower part of clivus. It is looking
Clivus.
like C1 tubercle, but it is not. It is shaped
Okay.
like that because of it is concave posteriorly because of that bone which is impinged between dens and the clivus. So that
This is the clivus.
pyramidal shape bone which you see is upper part of C1, dystrophic C1,
Okay, sir.
sclerotic dystrophic C1.
This is the C1 and this is the dens.
Correct.
And
The posterior can be lower edge of occipital bone or it can be C1, depending on how this thing is tilted. But it is most likely occipital bone, foramen magnum rim, because it is contiguous with the anterior clival bone. Okay, so the canal is compromised maximally at this level. If you go on the right image, it is 1 or 2 levels below where the canal is wide enough.
yes. Okay.
Coronal sections are not sufficient. There is only one coronal section and you cannot comment much on that. You should always display coronal sections where you can see the OC1 joint and C1C2 joints.
Okay, sir.
Any vascular abnormality?
None, sir. Both vertebral arteries are. There's no anomalous vertebral artery in the.
Sir, sorry to interrupt, sir. We'll have to make this quick. We'll have to shift to the second case also.
Okay, sure.
Yeah, sure. Yeah, show the MRI. Any additional information you are getting from MRI apart from what the images we have discussed?
One, there is formation of syrinx, sir, and
Okay.
two, there is slight tonsillar herniation, and
If the multiple intensity lesion seen anterior to the odontoid is not a dystrophic C1, what else can it be? And what is that pathology called? It is something which occurs in infective inflammatory lesions. What is it? Dr. Chaitanya? Is it?
Gristles?
No, what is it called? It's called pannus. Okay. Pannus. So this could be pannus. He could be having an infective inflammatory pathology underlying also. We don't know. Could have caused so much bone destruction and erosion at that level.
okay.
If you don't have CT and you have only MRI, you can call it differential as a pannus. Destruction of C2 body and odontoid, C1 arch, and everything is looking like pannus. That's what sir wants to tell you.
Yes. Okay, sir.
So what would you do in one line, Chaitanya?
So this looks like irreducible, and since there is more impaction from anterior side, best approach would be to go for.
So looking at 3 bones impacted and the very small OC1 or C1C2 joint, actually we do not have a good image because she didn't post lateral cuts at the level of in sagittal, and even in coronal it was insufficient. But looking at so much of impaction, it is very difficult to manipulate that. It's easier to go anteriorly drill it, and you'll have a foramen magnum also widened so that you don't need to do FMT.
Yes.
But obviously you need fixation after anterior decompression.
Yes.
What do you think, sir?
I also agree totally with you. Mere C1, C2 distraction may not be sufficient with so much impaction and settling has already occurred.
And you can correct the clivus canal angle also to some extent, reduce the hyperlordosis
Yes.
if you go anteriorly.
Yes.
Okay. Prashant, should we move to second case?
Yes, sir. We can move to Dr. Chaitanya. Dr. Chaitanya, can you share your screen?
Do I have access? Or I'm not able to?
Sir, meanwhile, I have a question.
Go ahead.
In cases of suspected CVJ instability, how do we check for neck muscle power, sir? Like, are we allowed to check for the neck muscle power?
So you first check his active movements, guarded, because patient will not go beyond his painful or movements where compression occurs. And then in that range, you can giving resistance, check the. Other is
The only test which is not allowed if you suspect a CV junction anomaly is
Passive.
neck flexion.
Yes.
Do not even attempt a neck flexion or tell the patient to flex his neck.
Yes.
But there can be chin tuck when you have studied when you were studying about the strap muscles, how they gain strength, how these singers they develop good tone by exercising them, by placing their hand under the chin and exercising those muscles. That can be done. And of course, the side to side movement is definitely allowed. And as Dr. Ranjit told, you should always be active only. Do not attempt any
Passive.
passive.
and you can do isometric testing, like ask the patient to lie flat on the bed, then you hold his neck, do not allow him to move, and ask him to lift, and you judge the power without moving. Same way, you put your hand below his occiput and ask him to push your hand. That's isometric testing.
Thank you.
Dr. Chaitanya, can we have your screen?
Sir, do I have privileges to share?
I think yes. Both of you have privileges to share. Can't you see that green button, share screen?
Press anywhere on your screen. You see a menu below. The fifth in line is share. There's an upward arrow.
I'm using a browser, so I'm not able to see this.
Yes, with the browser, you can just tap anywhere, click anywhere on the screen, and the baseline will appear. On that lower button, there are 6-7 buttons. The fifth button is share. Take your mouse and touch click anywhere on your screen.
So I've gone through a different device.
Okay, well, right.
While Dr. Chaitanya is setting up his screen, some of the aspects regarding these CV junction anomalies, Dr. Meghna was commenting that the sensory exam was not coming forth as well. But there are some leading questions in sensory exam we can ask them. One is regarding Lermit phenomenon. If it's a very simple question to ask, and if they have Lermit's phenomenon, it helps you in two ways localization. One, you can say that his posterior column is definitely, and that too from mid dorsal to upper cervical. Anywhere posterior column is affected, they will have Lermit's phenomenon. That is one leading question that you can ask. Second is band-like sensation. That most of the patients, even though they are very, but they may not tell correctly during your sensory exam. But band-like sensation, you can always ask. They will definitely tell that band-like sensation is present or not. Then the difference between pain and temperature. That is also difference between pain and temperature, difference between touch and pain. That also, some of these patients who are intelligent, they may not be very cooperative during testing, but when you ask them, they will tell that I know that mosquito is biting me, that pain I definitely know. But when I take bath, I don't feel that cold water is applied onto my skin. So these are the subtle clues that you get. But I think Ranjit sir will agree with me that now it is the retrograde diagnosis which is being practiced, that see the image, then try to correlate with the signs. So,
Correct.
but this will give you clues that. So let me ask Dr. Meghna, why is this? Why are we? Both of us were very pertinent about this autonomic nervous system. Why? Let the patient have some autonomic findings. What is that? Let him have some bladder symptoms. It is like motor symptoms. Why are we giving so much importance? Or I can put it in another way. You you are supposed to post only one case for tomorrow in your OT list. You have two patients of similar pathology. One patient is crying with pain, excessive pain, same pathology, and the other patient is not having so much pain, some numbness and all are there, but his bladder is involved. Who will you post for early the next day? Only one OT is available.
The one with the bladder involvement will be posted.
Other person is crying with pain.
The one with the bladder involvement.
Yeah, why? Why? The question is why? You are correct. Absolutely correct. Why? Because autonomic involvement means near irreversibility of neuronal dysfunction. If you don't save him, then his neuronal dysfunction is going to persist for life. Irreversible. Understood?
Yes.
Second important is always have a good assessment of his respiratory risk. Because you have to counsel them prior to surgery that there's a very good chance of them going into ventilator, tracheostomy. Okay.
And you must have come across Meghna patients who, with this either megaodontoid or BI, when there is real lower medullary compression, they come with a very shallow, rapid breathing.
Yes.
And that time you need to take them for emergency decompression.
Yes.
It's like Kodai Koena. So actual what questions are asked, the answer is that the bladder one I'll take up tonight, emergency, and the next one I'll post for tomorrow.
Dr. Chaitanya, are you ready?
Yes, sir.
Can you share your screen?
I think he's getting another laptop ready.
In the meanwhile, Prashant, can you tell us the rules for this OSCE?
Sir, Dr. Harsh will share the OSCE, and there are questions already written there. Each candidate has two OSCEs each, so that would be it, sir. Yes, we can see your screen, Dr. Chaitanya. You can proceed.
So this is a patient, Mr. K, who's a 39-year-old male who has come with complaint, who's a resident of Bihar, and he is by education he has passed 12th class and he's a welder's assistant, and he's right-handed, and informant is himself and he reliable. So patient has come with chief complaints of weakness of the left upper limb since 11 years, thinning of the left hand and forearm since 8 years, weakness of right upper limb since 2 years, and thinning of the right hand since 1 year. So patient was apparently all right before 11 years. Then he experienced weakness of grip of left hand, slippage of bucket of water at home 11 years ago, which was insidious in onset, occurred multiple times while carrying or gripping heavy objects. Symptoms were gradually progressive, painless. Patient had difficulty gripping or lifting objects with the left hand, buttoning of shirt, and he complains of symptoms occasionally aggravated due to cold weather. And he also complains of decreased range of motion of the left wrist, and the symptoms gradually worsened until loss of hand grip and dexterity of the left hand since 3 years. So patient noticed thinning of the left hand since 8 years, initially in the region of back of the palm near the thumb, followed by palm near the little finger, gradually progressing to involve the ulnar side of the forearm. And he has history of lifting heavy weights in gym after onset of symptoms for short duration around 7 years ago. And patient had no difficulty combing hair, lifting arms overhead, or bringing mobile phone to the ear. He does not have any tightness of upper limbs or lower limbs. He was able to distinguish between hot and cold water and objects by touch. And he had no difficulty turning to one side in the bed, getting up from bed or a seated position. He had no complaints of neck pain or decreased range of motion of the neck. Patient then experienced similar complaints in the right upper limb since 2 years, with weakness of grip of the right hand while lifting hammer or heavy objects while working as a welder's assistant. Also insidious in onset, gradually progressive, painless. He complains of difficulty completely extending the fourth and fifth fingers since 1 year. So patient noticed thinning of the right hand beginning at the back of the hand near the thumb. So there's no history of trauma or carrying heavy objects on the head. No history of pain, paresthesias over the upper limb or the lower limb. No history of heaviness, tightness of proximal parts of the upper limbs. No history of neck pain, electrical shock-like sensation while bending the neck forward, or any neck deformity. No history of decreased range of motion of the neck at shoulders, elbow joints. No history of imbalance while walking, difficulty walking in narrow lanes in darkness, or imbalance while washing face. No history of fever, redness, or deformities of the joints of bilateral upper limbs. No history of decreased sensation, numbness over bilateral upper limbs, or no history of decreased sensation of the body. No history of loss of sensation while washing perineal area in the washroom. No history of fatigue of upper limb after activity. No history of tremors or involuntary jerks of the limbs. No history of backache or lower limb weakness, paresthesia, or difficulty walking. The patient does not have any complaints of bowel or bladder involvement. No history of fever, chronic cough, or night sweats. No history of diplopia, dryness of eyes, face, drooping of eyelid. No history of cough headache. No history of difficulty swallowing, cough while swallowing, or difficulty with speech or nasal regurgitation. No history of shortness of breath while talking or at rest. So in the past history, the patient has no known comorbidities, and he has history of cement burns over the medial aspect of right arm 7 years ago. And personal history takes mixed diet, no addictions, and no similar complaints in any of the family member. To summarize the history, this is a 30-year-old male who was presented with A chronic, gradually progressive, painless, asymmetric, flaccid paresis of bilateral upper limbs, predominantly involving the distal muscles of the hand and forearm, associated with atrophy of involving the left upper limb since 11 years, followed by the right upper limb since 2 years, without sensory disturbance, no involvement of the lower limbs, sparing of the sacrum and bladder functions, suggestive of a lower motor neuron disease of bilateral upper limbs. The substrates involved with the vertical extent at the motor level being C7 to T1 and horizontal extent being bilateral anterior horn cells.
That was fairly well described. Dr. Meghna, anything else you would like to ask Dr. Chaitanya?
Whether he was able to differentiate hot and cold sensations, sir, because he had a history of cement burns. I wanted to know if
I've mentioned this was a separate incident which happened, which was an occupational hazard. But I've mentioned in the history that he has history of differentiating hot and cold water and also distinguishing objects on touch.
So historically, your substrate being a pure intramedullary location at the level of C7T1
Yes.
in a young adult, 30-year-old young adult.
Yes.
What could be the possible pathologies which can occur at such a region? Possible pathologies.
With this substrates involved, I would, and the age of the patient and the nature of the disease, initially I would go with following, disease involving the anterior horn cells, so a motor neuron disease. For examples like Hirayama disease, or to distinguish more, I would also consider syringomyelia, but there's no sensory involvement or spasticity in this patient, or any neck pain, suboccipital headache in the patient. I would also consider
there are a couple of entities where syrinx can develop without tonsillar herniation. You must be aware of.
yes.
So can you tell 3 conditions where syrinx can develop without tonsillar?
In case of arachnoiditis, infective causes.
Post-traumatic.
Post-traumatic.
Post-traumatic, yes. Post-traumatic syrinx can form without tonsillar herniation, yes. But he does not have a corroborative history.
Yes.
Then any other instance?
Arachnoiditis.
No, that arachnoiditis only causes syrinx. Post-infectious, post-traumatic syrinx can occur. Totally agree with you. Any other associated syndrome you know where it is a named syndrome? Chiari zero, have you heard?
sorry, sir.
Chiari zero. Chiari zero.
Chiari zero, yes, sir.
Chiari zero, we still don't know why it happens, but there is syrinx formation without tonsillar.
Yes.
And the last one, intramedullary tumors.
Okay.
Yes.
This could be the beginning of an intramedullary lesion, a tumor.
Yes.
You were mentioning some vascular pathology. So, what are the vascular pathologies which can cause bilateral anterior horn cell destruction?
ASA syndrome, ASA
yes.
scheme of ASA can be one, and or AVMs in the region.
Steel phenomenon. Have you heard of steel phenomenon?
Steel, yes.
Yeah. What is the classical condition which produces steel? And the cord goes ischemic. Maximum affected will be anterior horns.
Subclavian steel phenomenon.
Steel phenomenon.
One I've heard is
I
subclavian
hope
steel
for
phenomenon.
theory exam also you study the classification of AV fistulas, dural AV fistulas.
Yes.
So there is one variety of AV fistula which is notorious for the steel. Understood? So dural AVF is a notorious cause for this bilateral anterior horn cell steel phenomenon causing. Syrinx can cause anterior horn cell destruction. MND can cause anterior horn cell destruction. Yes.
Yes. Should I continue, sir? So should I proceed with the examination? So on examination, patient is conscious, alert, cooperative, moderately built, and with normal vitals, BMI of 19.6. So we have, this is not underweight, he is normal for his BMI. Neck height is 11, neck height ratio is 1:14, arm span of 170 centimeters, hairline is normal. Normal gait and stance, no neurocutaneous markers or phenotypical markers. On systemic examination, respiratory, breath holding time is 49 seconds. Single breath count is 21. On inspection, he has an abdominothoracic breathing, no accessory muscles involved. Chest expansion is 5 centimeters, normal resonant with normal diaphragmatic expression. Normal air entry, no added sounds. CVS and per-abdominal examination is unremarkable. Spine examination, no deformity, deviation or tenderness, no neurocutaneous markers. Bilateral shoulders and scapulae at the same level. Higher mental functions, MMSE of
So you can go to positive
cost.
findings. We waste time. What is the important one to mention in cranial nerve examination for such a case?
One is 11th nerve or involvement and lower cranial nerves involvement. Normal shoulder shrug.
Tongue fasciculation and atrophy.
No meiosis.
That you should
no
definitely
nephritics.
mention. Tongue fasciculation and atrophy. Rest you can continue. Okay, go ahead.
On motor examination, attitude of the patient, he has bilateral ulnar claw hand. There are no fasciculations noted. Bulk is lower on the left side. It is decreased on the left side. At the arm 22 centimeters and forearm 18 centimeters. There is wasting noted of atrophy or noted of the thenar and hypothenar muscles. First dorsal interosseous of the left hand. Hypothenar muscles and first dorsal interosseous of the right hand. Medial aspect of the forearm, ECU with sparing of brachioradialis, with prominence of the medial epicondyle. And tone, bilateral upper limbs, there is lax at the left wrist and wrist joint and fingers. Bilateral lower limbs are within normal limits, MAS of 0. Radial pulse is normal. Capillary refill time of 2 seconds, no tenderness. Tinel sign is negative, Fallon's test is negative. There's a clinical image showing wasting of more predominant on the left side, the hand and the forearm, and sparing of the brachioradialis. This was a video which was showing weakness of adduction, abduction, and opposition of the left thumb and palmar and dorsal interosseous, the interosseous and the lumbricals. So power weakness was noted first at the left triceps, which is 4- by 5. Pronation supination is normal in both limbs. Wrist flexion is affected in the left side, which is 4 plus, and wrist extension is 3 by 5 in the left wrist. And thumb, he is unable to abduct or oppose in the left thumb. And right thumb, he is able to abduct and oppose, but weak adduction. And finger flexion at the MCP joint is 4 by 5 at the right hand, 0 by 5 in the left. Lumbricals and crochet are weak in both the hands. Lower limb power is 5 by 5 in both limbs. So reflexes, superficial reflexes are present. Babinski's bilateral flexor. Deep tendon reflexes, there's areflexia of left triceps jerk and supinator jerk. Hoffman is negative. Knee is bilateral 2 plus. On sensory examination, sensations are mostly preserved and intact, except for a small patch of loss of crude touch, 20% loss over the C7 dermatome over dorsal aspect of left hand. Joint position sense and vibration sense is intact. Perineal sensation is normal, and cerebellar tests are negative. Romberg's is negative. To summarize, 30-year-old male presenting with chronic, gradually progressive, painless, asymmetric, flaccid paresis of bilateral upper limbs, predominantly involving the distal muscles of hand and forearm, associated with atrophy of the left upper limb since 11 years, followed by the right upper limb since 2 years, no involvement of lower limbs, sparing of sacrum and bladder functions, motor weakness of forearm, intrinsic muscles of bilateral hands, motor level of C6 to T1, hypotonia, and left triceps jerk and supinator jerk areflexia, reflex level of C7 and C6, and a decreased sensation over the left C7 dermatome. So element disease affecting bilateral anterior horn cells at a vertical level of C6 to T1 levels. Motor level C6, reflex level C6, sensory level C7. So element disease involving the bilateral anterior horn cells of upper limbs involving left more than right at the vertical extent of C6 to T1.
Dr. Meghna, anything else would you like to ask Dr. Chaitanya regarding the physical examination? Autonomic system we presume to be normal, Dr. Chaitanya? No autonomic disturbances?
No autonomic disturbances.
So when one segment or two segments of lower motor neuron symptoms and signs are being described,
Yes, sir.
the localization need not alone be due to anterior horn cell affection.
Yes.
So what are the other possibilities which you should keep in mind? Here it is bilateral, sometimes it may be predominantly unilateral or asymmetric. So what are the other levels of localization possible for wasting of upper limbs?
Polyradiculopathy.
So considering element type of disease, it can be at the root or root radiculopathy, peripheral nerve root involved.
Yeah, first and foremost is peripheral nerve.
Plexopathy.
Plexopathy, yeah. So
Neuromuscular.
how did you rule out plexopathy after your examination?
So plexopathy, for this level, there was no uniform loss of sensation. Like all sensations are not lost in this patient; they're intact.
In other words, there are some nerves bypass the plexus.
Yes.
There are some nerves which originate directly from the roots, bypassing the plexus. So roots, trunk division, and the nerves. So which examination is very important in such patients? Whether you want to know whether a particular nerve which directly bypasses the entire brachial plexus and supplies a very important muscle. What is it?
This, for example,
Does he have veiny of scapula?
no, sir. So, examination of the latissimus dorsi or serratus anterior.
Exactly.
Dorsal.
So that is the most important, or one important sign that you get regarding involvement is the
Veiny of scapula.
LD and serratus anterior. So these nerve to subclavius, but difficult to examine, which bypasses the plexus. So plexopathy you can rule out. Then comes root and intrinsic spinal cord lesions. So how do you differentiate between them?
So, for a radicular involvement patient here does not have any radicular pain, and the symptoms are not along a particular dermatome involving single root, and
Strict dermatomal involvement,
it is bilateral.
differential involvement of the tracts, differential involvement of the tracts, not uniform involvement of all tracts together. Differential involvement of the tracts. Then strict level is possible where, and a very vague level is possible in
Strict level is possible in compressive in a root radiculopathy.
So can this be something, a medical neuronal disease?
Yes.
No compression at all. Is it possible?
For a non-compressive lesion, it has to be vague and diffuse, and they are usually bilateral, and the onset is more acute.
Will they be painful or painless?
They will be
Will there be waxing and waning or steady progression?
The onset is more acute, and there may be waxing waning, and without painless involvement.
So shall we go to investigations?
Yes, sir.
Yes, sir.
Ranjit sir, any more questions? Shall we go to investigation?
Yeah, let's go to investigation.
There's a dynamic X-ray done of the patient, which is showing loss of lordosis, loss of cervical lordosis, or straightening of the C-spine. With there is no listhesis or CVJ anomaly which is noted here.
What about posterior elements in the X-ray?
So enlarge this third image, the flexion X-ray.
Yes.
So what do you see? Follow the posterior spinolaminar line.
It seems intact, so there's no disruption.
There is anterior
So
subluxation of
in a
C1.
smooth line, or is there any disruption?
Sir? Could you repeat, please? I didn't hear.
So look in the neutral or extension, and then look in the flexion. Posterior spinolaminar line. The anterior subluxation of C1 or C2. It may not be necessarily related to current presentation, but there is subluxation moment, few millimeters, and it is getting completely reduced in extension.
Yes.
Dr. Chaitanya, in this era of dynamic CT scans, which gives you very good information, what is the current important role of these X-rays? Where do you want to do X-rays? Dynamic CT you can do. Any role for X-rays in the present era? Dynamic X-rays. Not only of cervical spine, take lumbar spine also. Why do you want to do a lumbar spinal X-ray, flexion extension neutral, rather than CT, where you can easily do a flexion extension? This gives only lateral view. The other will give you a coronal view, most important axial view also. Any importance for X-rays in the present era? Dr. Meghna, any importance?
Sir is asking, why would you prefer X-ray
Advantage
in
over
place of
CT.
CT scan, especially in lumbar pathology, in dynamic X-ray?
Even static X-ray of the cervical spine carries much importance. In what way? The single view where you describe the...
One important is the position of the patient.
Okay.
Because he's standing in these X-rays.
Exactly.
That
When
is
you are
bed-
standing, what acts on your each vertebral body and
So the load, the
axial load?
Basically, you do a weight bearing X-ray. CT scan, you cannot do weight bearing.
yes.
Have you seen some CT gantries where the patient is put in a very abnormal fashion and you may diagnose that straightening of spine is there, kyphosis is there. But the X-ray is only the free investigation where there is no neck constraint at all in the static. And in dynamic, as Dr. Ranjit told, it is the only weight-bearing investigation available, unless you have a standing CT and standing MRI, which is being developed in some countries, not yet available commercially. So this is the only weight-bearing investigation. So even minute instability will come into view, which may be hidden in a lying down position, flexion extension neutral. Okay, can you go to CT and MRI? We are running out of time.
These are videos are not able to play.
Can we have the MRI first, then CT?
This is a sagittal T2 MRI of the CVJ with C-spine. So there is a decrease in canal diameter from the cord diameter from the 5, 6, 7 levels with the syrinx from C4 to C7. And this is a neutral MRI.
Your clinical localization was to C7T1. That is the cord segmental level. So against which vertebral body will your maximum concentration be while analyzing the MR?
For cervical, it will be
What is the rule of thumb?
One level above. In
Lower
cervical.
cervical, it can be 2 level also. So C7T1 means your maximum attention should be focused on the against which vertebra?
5.
Yeah, 5 and 6. So do you find anything abnormal in 5 and 6 region? Intrinsic cord signal intensity changes are there or not?
There's syrinx formation and myelomolistic changes also.
Yeah, analyze with the axial also and T1 also to be very sure. Will T1 sequence help you in comparison with T2? If there is corresponding hypointensity in T1 where you see hyperintensity in the cord in T2, what is your inference? You have heard of the terms myeloedema, myelomalacia?
Yes.
Yeah. So it is pathognomonic. You have to see T1 sequence also, right?
Yes.
If you find myelomalacia, but there is no significant cord compression anywhere, what are the possibilities? Suppose in the C1, C2 region of the cord, you find significant myelomalacia, but in the neutral image, there is no cord compression at all. What will come to your mind?
Any ischemic pathology?
Oh, first, you should think of a reducible instability. So in the neutral image, it is getting reduced. But due to repeated trauma, when he is flexing his neck, that region of the cord is getting impinged. Myelomalacia is already developed. But in a neutral image, you will not see any compression. That is one. Second, you are telling about vascular. What is the vascular element you want to bring in?
Any cases of chronic ischemia which can be caused by...
Yeah. What is that called? What is that disease called? You are mentioning this is a static MRI, which means that there is a role for dynamic MRI. What is it?
So what are your differentials clinically after all the history and examination in this case? Main two differentials.
First differential will be Hirayama disease.
Hirayama versus
syringomyelia.
Syringomyelia. Without any sensory involvement over 10-11 years, syringomyelia is unlikely. What is the disease that all neurosurgeons fear once they operate and if they feel that it's still progressive? When you say
you should not be operating on such patients. You should avoid surgery in such patients. What is that substance?
So when you say anterior Hansel, the first thing that comes to your mind is motor neuron disease.
Amyotrophic lateral sclerosis. Yeah.
AML. So till now the differentiation, clinical and radiological and electrophysiological between Hirayama and MNT or amyotrophic lateral sclerosis.
Sir, Hirayama is has an onset which is at the younger age, whereas ALS is more common in the older age group. And ALS can involve other regions of, not just cervical. It can also involve the cranial.
So when you have a patient who has such a prolonged history,
yes.
What do you think of in such patients first?
Among the differentials, sir?
Yeah, how do you differentiate between MND and Hirayama? Purely on progression.
MND is has a more acute onset.
No. How will you counsel the patient? Suppose he is a diagnosed MND, what will happen to him after years of progression? What will happen to him? Which will not happen in Hirayama.
In Hirayama, the patient will have there's a possibility of plateauing or
so he will progress to certain extent and then plateau. Most forms of MND, they have relentless progression. and it is fatal.
Respiratory injury. So both Meghna and Chaitanya, can you tell one watershed area of the spinal cord each?
C71.
What are the watershed areas which are most vulnerable for ischemia?
One is C71.
T4, T6 area.
Yeah, one is mid dorsal, that is D6, D7 level, notorious for watershed. Yes.
Okay.
Sir, sorry to interrupt. Can we proceed for OSCEs?
Sure, Prashant, you are the timekeeper. Yes.
Dr. Harsh, can you share the OSCE? Can you share your screen for OSCEs?
This thing, you'll have to stop sharing. Somebody has to stop sharing. Then I.
Yeah. So here, the first case scenario is a 40-year-old lady who complains of headache for 1 year, right upper limb followed by lower limb weakness since 10 days. So what is your diagnosis? Are we first going with Chaitanya? Chaitanya, can you start?
So as an acute onset hemiparesis, which is lower limb weakness. So with acute onset, this appears to be a high-grade glioma of the left parietal cortex.
Sir, your comments, sir. Yes, you can see. Now see the scan and also tell your plan. You see Harsh is pointing towards something.
Yes.
Can dural-based lesions behave so? Exist for 1 year and suddenly deteriorate? What subset of dural-based lesions behave like?
Yes, sir. Atypical meningioma.
And what is your plan?
Parietal, left parietal craniotomy and gross total excision.
What are the grades of excision and the recurrence rates?
So Simpson's grading is used, in which 0 to 5 are used. And for 1, it is 9% to 19%. 3, 29%. 4 is around 40%.
Okay.
And 5
So the HP comes as a grade 2 meningioma with the residual. What would be your plan now?
Grade 2 meningioma is low grade, so we can just observe, like follow up the patient with serial imaging.
No radiation, no nothing.
Grade 2 meningioma.
Sir, any comments from your side, Ranjit sir and Krishna
Gross
Kumar
total
sir?
excision has been done.
Any other molecular marker will help you to see if they will grossly increase in size. Is it worthwhile to wait and watch or straight away? What are the molecular markers which will help you in grade 2 to note their aggressiveness?
Sure.
one specific recent marker which is used now routinely in glioma also.
I'm not sure, sir.
Okay. It's the second case. We have a 70-year-old man with bradykinesia on movement since 10 years, tremor while walking since 15 years, rigidity since 10 years. What would be your diagnosis?
So this clinical triad suggestive of Parkinson's disease.
Okay. Now, what would be the medical management and the workup for Parkinson disease?
We use a UPDRS medical management would be Syndopa in this condition, and UPDRS scoring is used.
Okay. Can you name the scoring systems?
And UPDRS is used.
Okay. Harsh will show you the scans. Patient has severe dyskinesia in on state. What would be your target?
These are two scans basically. There are two targets of DBS for Parkinson's disease shown. Tell me which scan is showing what target. The left one is showing what and the right one is showing what. These are the exact cuts in which you will target them.
So the left one is showing STN.
Okay, subthalamic nucleus. Right, left?
The left one, sir.
The left one is showing STN, then where is the red nucleus?
Left and right, I think what Harsh is showing may not be.
Yeah.
What is under Q3? Doctor, what is under Q3?
Q3, exactly.
Q3,
Yeah.
just below Q3, what is the target? And there is a sentence called target with a question mark. One scan is shown below that. What is that target?
Not sure, sir.
Dr. Meghna, what is this scanner depicted under the term Q3?
GPS, not sure.
Globus pallidus, okay. And below this, where the target with question mark, what is that? What is that target? You can see a hypointense region also, well depicted. Which is one of the favorite targets for DBS. You're correct, you can tell.
Subthalamic.
Subthalamic. Okay. So if dyskinesia predominant, tremor predominant, there are two subsets now. So for dyskinesia predominant in on state, what will be the chosen target nowadays, especially 70 years old, where brain atrophy is there, your targeting may be difficult. Larger targets are better than smaller targets, size-wise.
Okay.
Okay.
Can you proceed to the next case? What are the contraindications for DBS in Parkinson's, Chaitanya?
The patient is stable on medical management. There's no indication of DBS. Or he has.
But any other contraindication?
In the workup, you do a lot of workup regarding language, psychiatry. All those things are targets. Patient is on blood thinners. There are a lot of contraindications for DBS in PD. So in the workup, you just said UPDRS. If the patient is psychiatric, would you like to put a foreign implant permanent in that patient? Is that not a contraindication?
It is a contraindication.
Yeah.
Altered mental status is an absolute contraindication. And please don't equate this with the epilepsy surgery where refractoriness to medication is an indication for surgery. Whereas in DBS, if you get a very good response to levodopa, those are the best candidates for DPS. Okay, good responders to levodopa are the best candidates for DPS, but due to their shortening of the on period, they are forced to take more medications. That will induce drug-induced dyskinesis.
Okay. We'll go to the
That is
third
why this
case.
question was.
Okay, scenario for you, Dr. Meghna. 58-year-old male, fall from height, pain in the upper back since 10 days. He has no deficits, and pain is not responding to medications. You can see the CT scan.
There's a wedge compression fracture involving the.
Okay, the question is, what is the T-leak scoring of this patient?
Wedge compression fracture of.
He's pointing towards the ligamentous complex. What are the components of T-leak scoring?
The type of fracture, the ligamentous complex, and
Integrity.
And
Deficits.
and the deficits. Yes.
Okay. Okay. The next question. What is your plan? And you can see. Can you see this hyperdensity? The procedure has been done. What procedure?
Can a percutaneous procedure?
Kyphoplasty.
Cement augmentation.
Kyphoplasty.
What is the difference between kyphoplasty and vertebroplasty?
Vertebroplasty. Something is used in the kypho.
A balloon is inserted first.
Chaitanya, you had your time, man. It is Meghna's this thing. Okay, what are the potential complications in this case? Especially with vertebroplasty or kyphoplasty?
There is one dreaded complication of vertebroplasty. No, not. Okay.
In other words, in the axial CT, doctor, what will you specifically look for before injecting any cement into any vertebral body? One particular aspect you have to see. You want the cement to be within the vertebral body, right? You don't want it to?
It should be in the confines of the bone, right? It should not
so what will you look in the CT scan, axial scan? It's a very good procedure to do, but it may bite back. In what way?
He's pointing towards
the canal.
So if there is a breach of, due to the trauma, if there is a significant breach of something, you don't inject cement because it will not stay there. It will.
And there is, even if the breach is not there, there is a small test that we do before putting cement.
Yeah.
What is it? And the second dreaded complication. First is the cement retropulsion into the canal, especially thoracic, is devastating. Lumbar still sometimes you get away, but thoracic it is devastating. And second complication, so it can enter the venous channel and cause embolism, which I have never seen, but known. So what you do is, after you put needle, you inject a little bit of contrast dye and look at the dye. If it extravasates into the canal, then don't put cement. If the dye disappears quickly, don't put cement. Two things. Okay.
Next.
Here's
a 54-year-old male with neck pain, radiating pain in the upper limb, and tightness in upper limbs. Have a look at the scan. here. Okay.
There is a C5, C6 PIVD with compression of the nerve root more over the right side, sir.
Okay. The questions are as follows. What is the
Thank you.
diagnosis? Now can you see?
There is OPLL in this patient, sir.
Which type?
What type of OPLL?
It's involving certain segments. So it is a
Segmental.
yeah.
Okay.
What are the other types? Other than if it is all along the
Long.
segmental, then
I'm not sure, sir.
Focal continuous mixed types.
Okay. Next question.
So in the axial cut, you see something very rare and very beautifully, apart from OPLL. What is it? Meghna?
Yes, sir.
It is calcification of the ligamentum flavum, including where it is originating from the medial edge of the superior articular process. Exactly everything is delineated, like a nice wide U.
Just
Even
under
if
the
you go
lamina.
to the under the lamina, even if you go to the MRI, it shows not only OPLL but canal
posterior
stenosis
element
at that
also.
level.
Yeah.
Posterior element is also significantly thickened. Look at
Yeah.
that black lines,
Yeah.
almost 6 millimeter.
They are very difficult patients to operate. So, results wise,
Yeah.
OLF patients behave not very nicely like OPLF patients.
Yeah.
Any other differential diagnosis for that?
Yeah, very important.
Other than
What is
OPLF?
the difference?
Another disease which you don't want to touch. What is that?
See.
Mostly goes to orthopedicians, but sometimes lands up in us. What is it? Mimics an OPLL, but it's actually not OPLL.
You see fusion at most levels.
Dish.
Yeah, what is dish?
Diffuse idiopathic skeletal hyperostosis.
Okay, thank you.
Okay. The next question was patient complains. What is your plan?
So upper limb only weakness post surgery.
No, what is your plan? What surgery would you offer this patient?
ACDF can be done in this patient, sir.
But the segment is behind the vertebral body. Segmental ACDF would be discectomy only. You need to think of something anteriorly and something posteriorly or something posteriorly. Ranjit sir, your comments?
If we don't have a particular plan for this patient, what are general plans for such kind of patients where you have segmental OPLL or contiguous OPLL plus canal stenosis plus something from behind? So what are the various approaches that have been taken, discussed over decades, but final conclusion has not arrived? Which is the line that you draw to decide on anterior or posterior?
See, he's pointing towards it, the line to be drawn. It's called
I like
one
that
of the
very much
alphabets.
because my name also starts.
One of the alphabets, I'm telling.
K line.
Yeah, K line.
So one is K line, and according to Dr. Meghna, which gives maximum dural freedom from compression, anterior approach or posterior? Suppose you do a corpectomy, actually how much percentage of dura gets relieved of compression? Your aim is to give 180 degrees, right? Entire anterior 180 degrees. Does that happen? Versus a laminectomy with lateral mass fusion, where you can go up to the laminar facet junction and decompress. How much dural freedom will you?
In corpectomy, we draw a channel, right? So that is what sir is asking.
So dural freedom wise, corpectomy is a very compromised procedure. It's not a vertebrectomy that you. So only for very focal selected cases you go for anterior approach. And of course, K line will guide.
Yeah.
Number of levels, K line, and how much freedom you want to give to the thecal side. That will decide your plan. And it is on a case-to-case basis. And all these are progressive diseases. Right? So if you select an approach which will address another 2 levels adjacent also, that will be ideal.
Okay, so patient complains of upper limb only weakness post-surgery. Is it possible?
So what surgery has been done?
Sympathetic plexus in this case, sir.
What surgery has been done if the patient lands up with upper limb only weakness post-surgery, and that too near shoulders? Has the procedure been done anteriorly or posteriorly? And what is the syndrome called?
There is an article on it. Several theories have been put forward. Even Ranjit sir, people have been avoiding screws in that level because relatives will blame the screw.
Blame the screws.
So that level, no screws for lateral mass fusion. 3 में करेंगे, 4 में करेंगे, 6 में करेंगे. 5 में screw मत डाल. At least your first 50 cases. That's the guideline for.
So have you not heard about C5 syndrome? What is the theory? You must have seen at least one case in till you reach SR. It is not very uncommon. However meticulous you do, once in a while, at least once or twice a year, you get into this complication. It's mostly reversible. It's called C5 syndrome. It is supposed to be because of when you operate posteriorly in presence of anterior compression, the cord shifts and the blood supply cannot, or the roots are adherent anteriorly, and that produces sort of anterior horn cell or root injury, leading to mainly deltoid and biceps weakness. What is Dr. Goyal nowadays advocating in such kind of pathologies? Chaitanya?
No idea.
Okay.
So he's advocating don't decompress, just stabilize. Just put
Transfacetal screws.
transarticular screws, facetal screws. Okay, next.
Another last question is, patient has drooping of one eyelid and anhidrosis post-surgery. What are the possible reasons? Which approach has been done?
Anterior approach has sympathetic involvement of the sympathetic chain can lead to drooping of eyelid and the Horner syndrome. Basically, patient has Horner syndrome. Approach has been done anteriorly.
Okay. That was it. Sir, your feedback, Ranjit sir and Krishna Kumar sir, for both the candidates, and then we'll wrap up.
Yeah, I think overall preparation was good. Presentation was very good. Meghna should have selected a few slides, images, which exactly point to the pathology, like deciding the plan. And I think, Chaitanya, did you go ahead with dynamic MR imaging for Irama?
Yes, sir.
Okay, so does it show any dural, extradural venous engorgement, shift of thecal sac?
Shift of thecal sac anteriorly is shown, sir, and from C4 to C7 there is a posterior epidural
Engorgement.
enlargement.
Okay.
And thinning
Okay.
of the cord also, C6
Yeah.
to C7.
Okay. Good.
Krishna Kumar sir, your comments and feedback.
Yeah. Equally applicable to both the candidates that the jigsaw is present, but putting the jigsaw pieces into the common shape, I think you should inculcate the habit of clinical examinations very meticulously and correlating each point with the available imaging, and do extra imaging if required. Then only the jigsaw will fall into place. So that analytical reading correlating the imaging with clinical findings or vice versa has to be strengthened. That is my comments. Otherwise, good presentations and keep it.
Okay. Thank you to both the candidates. Thank you, Ranjit sir and Krishna Kumar sir. With this, we'll wrap up
Thanks.
this
Thanks,
this
Prashant, for
month's
the
edition of
opportunity.
sir. Thank you, NSI.
Thank you.
So thank you, everyone.
Thank you, sir.
Thank you.
Thank you.
Thank you.
Good night.